Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1. Extract 1. Questions 1 to 12. You hear a cardiologist talking to a patient called Rosie Clarkson, who's been referred from the hospital's emergency department. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Right, so, Rosie, the emergency doctors sent me your details, but perhaps you could just tell me in your own words what's brought you here today.
Sure. Well, about 6 weeks ago in July, I noticed I was getting a sort of a dull ache around my shoulder blades. I do a lot of desk work, and I just thought it was because I was, spending too long in that one position. I didn't really think anything of it. But then we went out for the day last Sunday to a place by the sea. We often go there, but this time, when we walked up the hill to the lighthouse, the ache got worse and I came out in a cold sweat. I mean, I've never had that before, and it was strange. It seemed just to affect my hands and the soles of my feet. I also felt this really bad nausea. I've never had that before either. Anyway, my husband noticed that I was panting and puffing, which is unusual for me. Then both arms started to get this sort of tingling feeling. So anyway, I was a bit worried about this. I wondered if I'd got a bug or something, because I'm normally very fit.
Right. Yeah.
So on Monday, I went along to my GP. He had a look at me and he found that the areas where I was feeling the ache were a bit sore, so he thought it was probably some sort of musculoskeletal thing. But by this time, I was also feeling it in my chest. So he said just to be on the safe side, he needed to do an ECG. He did that straight away, and something wasn't quite right. So he said I needed to go to the emergency department. That's when I started to get a bit scared, really. Anyway, they did lots of tests, blood tests, a chest x-ray, blood pressure, and apparently everything was normal. But then they said I needed to have something called a stress test. I didn't even get to finish that one before the pain in my chest came on again, but this time even worse than before. They said that suggested something wasn't quite right, and there might be something wrong with my heart, that I needed to see someone about it straight away, so they sent me on to you.
Good. Well, I can understand this has all come as something of a shock to you, but I'm sure we can sort something out for you. How's your general health? You look pretty fit.
Yes, I get lots of exercise, horse riding every week and boogie boarding in the surf with my daughter. I don't smoke, and I check my BMI at the gym. That's 25, so fine. So's my cholesterol. I've never had problems there.
Any history of heart disease in the family?
None.
Excellent. And your family situation?
I'm married with just the one daughter, who's 18 now. She's off to university this year. I love my job. I'm a reporter. It can sometimes be quite stressful, though. I've covered some pretty tragic events over the years. But I've always thought of myself as quite resilient. But actually, well, even before this latest problem, my self-confidence did take a bit of a knock because I had to have a mastectomy 4 years ago. It came as a bit of a shock. I just had a routine check, so I suppose I was lucky it was spotted in time, but it really knocked me for six, especially the chemotherapy afterwards. It took me a long time to get over it, not so much physically. It was more that it was lurking at the back of my mind all the time. I just about got over it, and then this happened.
Well, Rosie, I'm sorry to hear that. But it's quite possible that this is nothing to worry about.
Extract 2, questions 13 to 24. You hear an osteopath talking to a patient called Joe Parr. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Now, Mr. Parr, I can see from your GP's notes that you've been experiencing some unusual symptoms recently.
Well, yes, that's right. You see, it's come on gradually over the last few months. The pain, that is. It began in my hips and it slowly got worse. It soon spread to my lower back, mostly on the right side. I thought I'd just been working too hard and a good rest would sort things out, but I actually find it the opposite. It's much worse after I've slept, and it actually feels better following a bit of exercise, which is hard to understand.
And is the pain still there in your back?
Yeah, but not only there, it's now pretty widespread. Makes me rather moody, to be honest, which isn't like me, because it's now on both sides and it's gradually gone into lots of different areas, like my shoulders.
Okay.
What's most annoying is it now hurts to walk sometimes, because it's even in my heels now, at the back of them, here. It's really quite tender.
I see. That must make things difficult. And have you noticed any other symptoms apart from the pain, I mean?
Well, I'm tired an awful lot of the time, and something strange I have noticed just recently is my eyes. I've noticed they feel pretty sore for some reason, and they're watery, too. And sometimes I can't really see properly. Things look quite blurred. I've lost my appetite, too. I just don't feel like eating half the time, and I used to be a really good eater.
And looking at your GP's notes from your last appointment, I see that she sent you for some blood tests?
That's right, and she told me the first one showed I had mild anemia.
Okay.
That could be why I've felt so tired these last few months, I guess. She said that the following test showed some inflammation, too, which she said was in the bowel. I think that might explain the loss of appetite.
And have you found anything that helps with the pain?
Nothing makes it go away for any length of time, to be honest. Though I do find that heat often soothes it, you know, heated pads and warm showers. But the pain always returns soon afterwards. Something which does seem to help a little is yoga. A friend of mine teaches it, so she showed me a few exercises to do. I mean, it doesn't get rid of the pain, but it seems to ease it. She suggested acupuncture too, which I tried, but I gave up after a few dozen sessions. It just wasn't making any difference at all. That was disappointing because it was quite expensive, actually. The same friend's just lent me her TENS machine, so I've started using that. It's a funny sensation, you know, the pads on my skin. And I'm not sure if it really helps or not, but I'll stick with it for the moment.
I see. And what about your family? Does anyone else have the same sort of problem?
Not that I know of. I mean, I'm an only child, and my dad died about 6 months ago. He had advanced lung cancer. My mum's pretty well overall. She even helps out sometimes with my work admin, which I really appreciate. I'm a plumber. I work for myself, and she knows how difficult it's been recently with this pain. It's affecting me quite a bit, to be honest. I mean, I still try to see my friends every weekend. We used to go 10-pin bowling, and I enjoyed that, but I don't go anymore. I can't seem to concentrate very well these days when I'm doing anything like that.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a hospital nurse talking to a patient about how to manage his catheter after discharge. Now read the question.
Okay, so those are the main things you need to know about how to manage your catheter when you go home. Now, do you have any questions or concerns?
Not really. What you said about showering? That isn't going to be easy.
Haven't you got a shower at home?
I've got one, but I don't like it. I prefer to have a bath. Anyway, I'll manage. Now let me check. I usually use a bit of powder and lotion after I've dried myself. Did you say that's okay?
Well, it's best to stick to soap and water and a clean towel.
Okay, not a problem. And you said I can clean out the collection bag with a mixture of water and vinegar.
But not malt vinegar. You want the white distilled stuff.
Right.
Question 26. You hear the manager of a residential care home for the elderly telling staff about the results of a recent inspection. Now read the question.
I got the report from last week's inspection this morning. Overall, we came out quite well. The inspectors gave us a grade of good in 4 areas. They said we were effective, caring, responsive, and well-led. Where we didn't do so well was in the 5th area, which is safety. I'll read out what they said here. Just a minute. Right. Medicines were stored securely, and staff received training and competency checks before administering medicines unsupervised. Staff were aware of the protocol to follow if they suspected a patient had been deliberately harmed, but they weren't always able to follow an appropriate course of action when dealing with unexplained bruising, because no ongoing process is in place to analyse such incidents or to identify any patterns or trends. Now, we've already taken action to look into particular cases referred to, but we need to think about how to make general improvements.
Question 27. You hear a nurse mentor in an intensive care unit talking to a student nurse about a patient. Now read the question.
Okay, this is Ellie Warner, who came to the ICU last night after valve replacement surgery.
Right.
So when they brought her in, the primary nurse hooked up her monitoring so we can tell what the heart rate is, along with the arterial line, which tells us what the blood pressure is. I then checked the other equipment to make sure everything was working properly.
Okay.
Now, she's post-op day 1, and this morning her endotracheal tube was removed and she was taken off the ventilator. So we're going to turn her and check she doesn't have any pressure sores and do some respiratory therapy to help expand her lungs and teach her some breathing and coughing techniques. It's very important that the lungs are kept clear so infection doesn't build up there. She's currently off the medication and we'll see how that goes.
Question 28. You hear an emergency doctor talking to his team about using bedside ultrasound machines. Now read the question.
We have ultrasound machines here in the department that we bring to the bedside to look at patients immediately without radiologist supervision. It's potentially a very useful resource, but it's very dependent on how comfortable practitioners feel obtaining and interpreting the images. It does take a lot of skill and a lot of reruns to get good at it, to really be able to know what you're seeing. When I was a student, I thought everything on the ultrasound looked the same. It took a while to gauge what I was looking at. Nowadays, there's generally a lot more teaching around this in medical school. But it's good to get hands-on time. So do any of you have any questions?
Question 29. You hear a junior doctor asking a consultant about a seriously ill patient who's causing problems. Now read the question.
Can I ask you about the guy in bed 6 with the spinal fracture? He's being really difficult.
Yes, well, what we have here is a non-compliant patient. This is a young guy who's been very independent, very active. I mean, he was a runner before his accident and a dealer in a merchant bank, so probably a high earner. And all of a sudden he's gone from being independent and functioning to being immobilized in bed, having to make decisions that maybe he isn't quite ready to make yet.
But he's been dead set against every conceivable thing we've been doing for him since day 1. So how's he ever going to be compliant?
Yes, it's a complex case, but you have to remember that he doesn't actually want to die. When he talks to you, his concerns are of the moment. He'll talk about his work, about equities and accounting. That tells you something.
Question 30. You hear an anaesthetist talking to a colleague about the postponement of a patient's surgery. Now read the question.
I'm afraid Mr. Lucas won't be having surgery later today. He's going to have to be rescheduled.
Okay, but wasn't Mr. Lucas the gentleman whose surgery was postponed last month? Because we needed the cardiologist to check him over and make sure he was fit to have the operation?
Yes, that's right. He was given the go-ahead in the end, once his condition had been optimised. Unfortunately, he seems to have developed a bit of a cough overnight. I said he should have called in first thing to inform us rather than coming in. He thought, or rather he hoped, it was nothing, or else it wouldn't make much of a difference.
How's he taken it?
He seemed upset at first, but he quickly calmed down. He accepts that we can't proceed with surgery if there's a possibility that a patient's picked up a virus.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear a senior nurse, called Belinda Shelton, giving a presentation about an outreach influenza vaccination project in Australia. You now have 90 seconds to read questions 31 to 36.
Good morning. My name's Belinda Shelton, and I'd like to tell you about a pilot project that my hospital here in Australia was involved in recently. This was basically an outreach influenza vaccination program. I'll give you a very brief overview of what we actually did and then discuss some of the lessons we learned from the project. We were particularly interested in investigating high-risk groups to find out whether they were missing out on getting flu vaccinations. So, for example, you might have patients with a range of conditions who are already receiving care from multiple subspecialists. Most of these patients will already have healthcare providers because of their pre-existing conditions, but these healthcare providers may not see their primary role as one of prevention via vaccination. Because of this, we suspected that many of these high-risk patients may not be getting flu vaccinations, even though they don't have to pay for them and there are well-established services for delivery. We identified key populations on 16 sites. A mobile nurse-led immunisation service attended each site to collect data on patient comorbidities as well as to administer vaccines. A total of 520 vaccines were administered, and data was collected at the same time through interviews with the patients. The most common comorbidity reported was diabetes. Rather than reflecting a more general health trend, this probably reflects the nature of the sites visited, which included 2 diabetes clinics, as well as centres for the homeless, refugee centres, and residential facilities. One conclusion that was suggested by our project was that it would be possible to improve the delivery of vaccines by appropriate identification of vulnerable members of the community. We found that lack of knowledge, language barriers, or cultural factors mean that some people may not be aware that they can have free vaccines. And even if they know that they don't have to pay for the vaccine itself, they may be worried that going to a primary care facility to receive it might involve some other sort of payment. And in some cases, they may not even know that they're in a high-risk group and that it's especially important for them to be vaccinated. Now, on to the lessons learned. On this project, we included 3 residential care facilities for elderly people. However, we found the aged population in residential facilities already have established guidelines and infrastructure in place to receive vaccinations from their primary healthcare provider. Providing a mobile outreach influenza vaccination service to these residents could have a negative effect on this system and create a problem in the future if the outreach service was no longer available. In addition, it became apparent after the site visits that the majority of vaccinations administered and the priority at those sites were for staff vaccination rather than for residential client vaccination. Although staff vaccination is important, this wasn't the primary objective of the project. One of the most important things we found out was to do with planning the visit to each site. We found that for success on the day of the site visit, it was a good idea to advertise and explain the service beforehand. Another consideration for future years, though, is to do with the fact that peak protection from influenza occurs 3 to 4 months after vaccination. And it's important to be aware of that when deciding on the date when it's going to be administered. And it also became apparent at many of the visits that this model of delivery involving a mobile nurse-led service could be applied in other areas. Feedback from both staff and participants indicated that there was a strong interest and demand for paediatric influenza vaccination and also for other maternal vaccinations such as whooping cough. We found that at many of the refugee sites, attendance was by families, particularly women with young children. It wasn't ideal to be limited in the scope of vaccination when there was both demand and opportunity for it. Similarly, at a number of the sites, pregnant women were aware that they needed protection against conditions such as whooping cough as well as influenza. And since both of these are recommended in pregnancy, this seems the way we should be going. What the project has shown us is that taking vaccines to vulnerable populations is well received. and remains an important strategy to maximise uptake. And this is true even within high-income settings with universal access to healthcare, such as Australia.
Look at Extract 2. Extract 2, questions 37 to 42. You hear an interview with an ophthalmologist called Dr. Marcus Kane, who's talking about age-related macular degeneration, AMD. You now have 90 seconds to read questions 37 to 42.
My guest today is Dr. Marcus Kane, who's an ophthalmologist specializing in age-related macular degeneration, or AMD. Dr. Kane, this is a very common cause of visual impairment in older people, isn't it?
That's right. It's the most common cause of irreversible sight loss in Europe. The macula at the back of the retina typically begins to suffer damage from the age of 50 onwards. It affects straight ahead rather than peripheral vision. In the early stages, a patient may notice problems adjusting from dark to bright lights. Then, as it becomes more severe, serious blurring occurs, so patients can't make out faces, for example. And that can be traumatizing. Indeed, the results can be devastating. What seems particularly cruel is that it prevents people from doing things they take great pleasure in, like reading, watching TV, and doing crosswords. What's called dry AMD accounts for 95% of all cases. Wet AMD is less common but more disabling because abnormal blood vessels grow under the center of the retina, then leak and bleed.
Could you tell us about a typical AMD patient of yours?
Sure, I'll call her Laura. About 15 years ago, Laura felt something in her left eye, but did nothing about it for several months, even though her mother had been virtually blind towards the end of her life. Eventually, during a routine eye test, an optician suggested Laura saw an ophthalmologist. Within a week, she'd been diagnosed with dry AMD in her right eye and wet AMD in the other. She was already almost blind in her left eye. In my experience, this sort of thing's very common. AMD affects one eye badly first, but in many instances it goes unnoticed because the other eye functions. 15 years ago, there was no treatment for AMD, and Laura's right eye eventually weakened too, so she's now registered as blind.
So these days, I believe diagnosis involves an OCT scanner?
That's right. Ophthalmologists have long favored OCT, which is optical coherence tomography. It's a scanning process using light waves. Until recently, the problem with this has been the cost of the equipment, but handheld OCTs have now become available, and they're less costly, and it's claimed that these make the diagnosis of eye disease accessible to everyone. But this is dangerously misleading. The device may be simple to operate, but you need trained professionals to interpret the results. Another diagnostic tool is the use of eye drops. These enable specialists to get a better view of the retina through a special magnifying lens. A fluorescein angiogram, where a dye is injected in the arm, may also be used. This shows up any leaking blood vessels in the eye, but there can be adverse reactions, including nausea and allergic reactions.
How are patients with AMD treated?
Until about 10 years ago, there was no treatment. But now regular injections of drugs, the so-called anti-VEGFs, can suppress the protein which triggers rogue vessel formation and leakage. These drugs are injected into the eye. About a third of patients find they can see substantially better as a result, but even more striking is that in about 95% of cases, the condition doesn't deteriorate. The drawback is that the drugs only last 1 or 2 months, and patients need frequent injections over long periods of time.
Tell us about the home monitoring trial you're involved in.
Leakage reactivates in about 30% of people. They need to be monitored, which currently means visiting a hospital. The idea of the trial is that patients regularly test their own vision in the comfort of their own homes. There's a paper-based test and 2 tests using electronic devices. Some patients are apprehensive about using the electronic devices. That's not surprising given their age, and because looking at paper and small screens is a struggle if you have AMD, the people chosen for the study have some way to go before they reach advanced AMD. The point is to detect problems early. The hope is that if these tests can be rolled out as standard, it'll free up time so we can concentrate on improving treatment rather than on monitoring patients.
What about stem cell treatments for AMD?
Well, pioneering operations were recently carried out on 2 elderly patients who'd lost their sight due to AMD. Stem cell patches were used to repair the membrane at the back of the eye. Within a year of the operation, both patients were able to read again. The story was seized upon by the press, of course. Stem cell replacement was even hailed as a cure for blindness. But certain details were conveniently left out in all the hype. For example, one of the patients had type 2 diabetes, and that was exacerbated, and neither patient actually achieved perfect vision. The idea of stem cell treatment is appealing, but the suggestion that it could become an off-the-shelf treatment within the next few years seems overly optimistic.
That is the end of Part C. You now have 2 minutes to check your answers.